Okay, first I want to so there's some people here that may not be as aware of BosLab, so I want to first thank BosLab for hosting this webinar, uh, and and also how I came to learn about BosLab. So first, so BosLab seeks to democratize science and allow those in the community that aren't in an academic setting to have access and be empowered to engage their curiosities and explore questions through experimentation in a community lab. And it's just so awesome. And I, last year, was looking at what some of the outreach that LMI could do. And we were exploring meetup options. And I was looking into meetups and how they work. And I learned of BosLab. And I said, oh, there's no way that there's a group out there that's giving people the ability to do community science. And as a natural fit, the spirit of LMI is engaging the community through science and our indication and support of addiction and mental illness. And in that regard, it was just a natural kindred spirits. And then I attended some of their meetings, actually, more than one, but the first one was a 3D bioprinting meeting. That was pretty awesome. And then talked to Wendy and further nonprofit passion driven and that got us where we are. And we were going to do this right before COVID or right around COVID, shut everything down, and I'm so glad to be here now. And so that's how I learned of BosLab, and that's why I think BosLab is a wonderful organization. And for those that aren't aware of it, now you are, and hope you can learn more about what they do. Okay, so now we'll get started. So I'm Joe. I'm a postdoctoral fellow over at I do a lot of the research at Massachusetts General Hospital, do the Department of Neurology at Harvard Medical School, and I do a variety of things that I can answer questions about. I actually don't go into too much in this talk about what I do, but I give an overview of addiction and mental illness, and mostly addiction. But what we do see here on the title slide are neurons that I generated from a patient that had mental illness. So and then we can talk about that more. So now let's get started. So a little bit about LMI, just a slide. We have a community advisory board, the scientific advisory board. These are our persons. One of our board directors is present on the call today, Laurel Parkus. We thank you. And our mission is to advance science, technology, and medicine to help persons living with mental illness and addiction. And we are a 501c public charity. And we can chat a little bit more about LMI later on at the end of the talk. But I just want to give a little overview and our passion to make a difference in this cause for people that are suffering. So now we have a couple questions because we want this to be a discussion. I don't want it to be where I just give you all this information. I'd like to have be a discussion. So I encourage your feedback. I encourage at any point that you would like. The first question is, do you know? I guess I do this question, Wendy. So have you?
I think if you hit polls, you
yep.
should.
Have you or do you know someone who has been adversely affected by substance use? So I'm going to launch the poll. You now have, you should have that poll, and you can answer yes or no. We'll get a few more.
Does this include alcoholism? Is that substance abuse?
Substance use, yes, anything. Alcohol or anything. Great, give it a few more seconds. So I'm going to end the polling, and we have 88% of people said yes, and 7 against 1. And those are the results. And it's not atypical just by numbers and connections. Usually we know somebody, and often it could be a family member, it could be ourselves, or somebody that we care about. Question number 2, is a whiteboard, and it just kind of to get us kind of loosen up a little bit in our conversations. But when you hear addiction, what do you think of? And I don't know, Wendy, if we can.
Yeah.
Do I stop my share to let you do it? Yeah.
Yeah. I think everyone has the freedom to select the text box and write, what they think about.
Well, this is something that I've been thinking about lately, and I hope you guys can hear me. But a friend of mine was joking the other day that in COVID times, it's like addiction to anything that feels good. So, so that could be. Well, we was joking that it's addiction to serotonin, or and whatever is generated just watching Facebook or Instagram, whatever that chemical is, but you're just addicted to it. And you look for an opportunity to get it, or even just addicted to playing online games without, just because it's a feeling of, it's this amazing feeling that you get, like, oh, I won, and of course you go down once you lost, so you go the same cycle as though you were a hard drug. That's all.
Yeah, kind of going off of what Arnaud said, if I'm pronouncing that right. I'm sorry if I'm not, but a lot of addiction goes beyond just general substance use. It can also go into things such as gambling or pornography. That's a big one. And social media usage. I mean, I'm trying to cut down on using my phone and social media as well. And just depending on these things has quite a profound effect. And for a lot of people, it can, for a lot of people, it can have a really profound effects, and they don't necessarily realize it, because it's just, a lot of people just see it as an acceptable thing to just be on social media all day or be viewing pornography every day.
Hello, this is Rob. I apologize. I added my answers to the whiteboard.
No, that's what we'd like you to do. I'm just adding it in for people who who are having issues. So please do. Yeah.
All right, great. Thank you.
And that's great. And I totally agree that addiction goes beyond just substances. There's other very addictive behaviors and addictive external, influences.
Oops. Sorry, I'm allowing people in, and I'm multitasking but not doing a good job.
We could probably move from the whiteboard in a few moments, if everybody feels like they've had a chance.
Yeah, I mean, these questions, or these thoughts that people have put down, really have broadened my, thinking of addiction.
Just think, all that just happened in like 30 seconds. Imagine in an hour.
Yep.
I like that we've moved towards the positive side of things that can happen. Okay, awesome. So I'll go ahead and pick up the presentation, Wendy.
Okay.
How do I?
You're allowed to screen share.
Yep. Awesome. Okay, so great. So wanted to get us just chatting a little bit. This is meant to be a discussion overall. And great. Awesome. Okay, so now just to kind of give us a framework for viewing these slides and just keep us oriented. So like every good story, there's a moral, and the moral of this story is never give up. And then it has a parable to it, and the ant and the apple, and this actually comes from a physics text on gravitation. But the parable is the ant will walk along the apple, always thinking he's on a 2D surface. Meanwhile, the observer, stepping away from the apple, sees the object he's walking on, the ant's walking on, as a 3D surface, and he gets that perspective. So we will go over some history to kind of gain that perspective, to kind of improve our lens of how these issues that we're discussing, and then also the theme of the presentation is people, science, and policy. So together these work together to affect how we experience these issues in our life. So, an addiction crisis, who and how many? And the point here is us, and it's just normal people, everyday people, all of us. We know somebody. 80% answered in the poll that they knew somebody. It's doctors, it's lawyers, it's rich, it's poor, it's everything. And then and it got to crisis proportions in recent years when nearly 200 fatalities per day. I want to just mention a little personal story. So Riley Farrell, I met his mom. His mom communicated with me and was consulting me for a little bit and saying that her son was having troubles. And then I got the message that her son was gone. And I didn't know what that meant. And she was like, he's really gone. And Riley, died from an overdose. He was 24 years old at the time he died. And just a story behind him. I mean, you see a little boy running around, cute little face with freckles, a good kid. You see it. Loves dogs, artist. This is the message his mom gave, and I'll let you read that, and get what you want from it. But his mom's heartbroken. His mom has experienced an immeasurable, unfathomable pain. And just to go a little bit on about Riley, just a little bit more in his words and actions, because this matters to me, and I relate to it. I relate to it because I wrote the same kind of letter before, and he writes, "I love you both. I love both of you. I have to do this on my own. Sorry I let you down. I love the both of you. I'm going to try again, and I promise you that, Mom, I love you, and thank you for the kindness you've shown me when I've been the worst." And I mean, I know that feeling. And then there's his to-do list. And this is a couple months before he passed away. And his things to do. Okay. And his mom has shared this with me, and I don't think that she gave me permission. Psychiatrist appointment, job, third-step prayer, be a man, follow through with my actions. His priority list is roles, goals, spiritual, son, financial, school. And Riley didn't make it. And I don't see somebody there who is flagrant against society, rebellious. I see somebody who's trying everything they can do to make a life for them that they the best that they can do. So just touching on, I term it as cognitive dysfunction. We can, it's not really typical terminology, but I just want to take a step and start going through a little bit of history, a little bit of framework. Just, how has these conditions affected humanity and their place in society, and just draw some parallels. So in mental illness, if you go way back from ancient times, it was viewed as supernatural. It was one view of it. Somatogenic means of the body, psychogenic of the mind. It's the way you could view it it's one way to frame it or express it. And then with addiction, we get similar kind of things, right? Moralistic or sin, bad people, things along those lines, or neurobiological, parallel to somatogenic, or psychological. Ultimately, you can see it as like kind of a biopsychosocial that we'll talk about in a second. But why we care about this is because it affects our treatment. It affects how people view you, it affects the medical or the social or the counseling or treatment that you'll receive. And for example, there was a period when they used to drill holes in people's head for mental illness, thinking to let out spirits and or even somatogenic value as well. But we care about this because how we view it ends up affecting the treatment. And so what's captured in this slide is just the complexity of the issue, and that, you know, through time, we've been kind of just cycling through the same themes over and over. And when one's less effective than another, then we kind of switch to our viewpoint, kind of on a pendulum, you know. And you know, there's been a lot of treatments that have been controversial from ancient to modern times. I just showed you one, drilling holes in people's head. And you know, and social attitudes are impacted by the tools of the era. So, you know, how we feel that we can be pragmatic or be of help, you know, impacts how we treat. And if we think that, you know, being compassionate is helpful, then society's been compassionate. If society feels like compassion not being helpful, then society might switch to something more harsh or draconian or punitive. But we keep seeing these cycles of just going through these various perspectives over and over again. And what's really needed is a comprehensive approach. And what's been emerging, I think, even better of late with improved tools, is getting towards that. But we don't win when we start breaking them apart and comparing, contrasting one versus another. So, you know, what does it look like, right? So the drug war. So, you know, Anslinger has been and has been known as the architect of the drug war, and is, you know, recorded and at this point exposed for being racist, or being, at least being racial, and racist would be fair. But what have we seen? We have seen since Nixon's declaration of public enemy #1 in the war on drugs, we have seen this exponential increase in number of incarcerated people. 7.5 million people in you know, in 2010s, you know, period, under incarceration or Department of Corrections or some type of probation or parole. 7.5 million people, and in general, just over 2010, over 2 million people. And how we compare to the rest of the world is we had the highest incarceration rate. That's a well-known stat, and it's getting a little better as we see in the last handful of years. But this is, you know, we have to really question, is like, this really where we want to be and what we want to be known as? And 40 to 50% of people in jail have been stated to have a mental health issue, mental illness. And we know that the vast majority of people in jail have been to possession of narcotics. So jails, institutions, and death. How did we get here? And, you know, and this just kind of get us to think about, you know, what do we want? And this is not, I don't think this is the society or the treatment or the approach that we actually really desire. So substance use and civilization, normal and pathological use. What has been society's relationship with substances? It's been used in religious ceremonies for medicinal purposes, recreational use. Priests and shamans, you know, used the famous little red and white spotted mushroom for thousands of years in Central Asia. In the 3rd millennium, Sumerians isolated opium from poppy seeds, and you know, pain treatment, you know, probably, you know, was launched. You know, it's been recorded sooner than that, or older than that, but it was pivotal change when Frederick Sir Turner isolated opium from morphine from opium. And Noah is recorded for leaving the ark and drinking and being drunk. And we know that it's well known that alcohol has been around for thousands of years. Pathological use is often affected by societal norms and reflects different time periods and cultures. So what actually is problematic use, you know, doesn't have a fixed definition, and is a reflection of the society at that time. Just a little bit of history. This is the kind of the ant on the apple, just the lens, you know, like, you know, how does this look over time, and, you know, how did we get to the way things are in 2020? So just a little bit of the people that were involved. So Benjamin Rush, father of American psychiatry. He's the first one to propose a disease model, or influential person, and appreciated for proposing the disease model of drinking, of alcoholism, reference to a disease of will. And revolutionary, innovative at the time, he advocated for sober houses, and these were consistent primarily of religious and moral instruction. He was a signer of the Declaration of Independence, and was, prominent during the Revolutionary War. Post-Revolutionary War, the Civil War, we got the emergence of the temperance movement that grew from, as it sounds, kind of moderation, and then when moderation wasn't effective, went to a total absence avocation. And again, we see this kind of tug of war of compassion and punitive, or moderation to abstinence, and we just see these themes recurring, through the decades and centuries. And Frederick Douglass, was a leader in the African American temperance community, and is noted for his use of mutual aid support, and one of the earlier persons to apply that method. The temperance movement is not known for being mutual aid support, which is interesting. So with the improvements in medical research, and I turned to the 20th century, we saw a rise in medical optimism, but it was short-lived. Things like immunology were being better known, and bacteria and just general pathology. And there became a support that there was toxins or antibodies that were related to morphine and morphine use, and good for abstinence. But this didn't last long. A couple things, notable about that time, and one of them is going to be the Harrison Act of 1914. And this is reflected that Dr. Alexander Lambert, who advocated, for medical support and research, abandoned use of the word cure in 1920. And that actually brings us to question 3. So this is not a poll, this is a discussion. When you hear cure for addiction, what do you think?
I think some sort of medication combined with behavioral therapy.
I think that it's going to have to be something totally new that we don't have already.
It's tough to, I feel like it's tough to say you can really cure addiction, because once you develop some sort of full-blown addiction, and then you get out of it through just abstaining from the substance, it's still very easy to get back into that cycle of addiction. So to necessarily say that you're completely cured, I don't know. I wouldn't really say you could necessarily 100% cure it.
Good. Right. So, and that's something to think about. And what does a cure mean? Is interesting to think about as well. And so federal drug policy becomes centered on law enforcement, and that is seen through the Harrison Act of 1914. This really sets the stage for the next 100 years to today, to modern day, for over 100 years. But I think things in the last several years are getting just a wee bit better. But some of the things that really changed in this act is that doctors were allowed to prescribe people that were addicted medication. So if you had morphine addiction, you could go get a prescription for morphine. You could practice maintenance through the doctor. The Harrison Act ended up determining that as malpractice and prosecutable. And so doctors quit prescribing; they would come under punishment, and that really led to just doctors getting out of treating people that are addicted. Really, it's really reflected in the medical. Until maybe recently, it's really reflected how doctors and the medical industry has really treated people with addiction. Nonetheless, the National Research Council in the 30s, even though maintenance wasn't really being supported, it was in a hospitable climate for it, they did start researching substitutes for morphine. There was a development in narcotic farms in Kentucky and Texas. You can see those images in the upper right. And the first successful substitute for morphine, heroin, or opiates is methadone. That was developed by Germans in World War II. And this is a little, not surprising, but the 60s we saw the development of naloxone, naltrexone, and you don't see these widely used or adopted for decades until really, I mean, I think that you would, even 5 years ago, there would be hospitals that didn't have Narcan or naloxone. Just notable things that IMH was established in 1949, and NIDA came on around 1973. Nonetheless, there's a tension here between the punitive practices that were born out of the Harrison Act of 1914 and acknowledgement that addiction needed research and wasn't going away. Some people are frustrated with the NIDA because they feel like for years what they did more than anything else was just show how bad drugs are or how addictive they are, or you know, their negative effects. And you know, putting rats in cages by themselves, for example, and expecting them to do something else besides drugs, you know, became kind of the way research is done. And there's some criticism on NIDA for how they based their research and what they were proving. So so with that, a little bit of the treatment industry of the 1900s and the early 2000s, and still exists to some extent today, was really dominated by the therapeutic communities. And therapeutic communities were born out of an organization called Synanon. And Synanon was actually founded by Charles Diederich. Charles Diederich later on became known as a cult leader through just the way that Synanon evolved over the years. And he ended up being convicted of conspiracy to commit murder of Paul Morantz because whether it was him or his Synanon members, they cut off the rattles off a rattlesnake and put it in Paul's mailbox, and then so he wouldn't hear the rattlesnake, and then it could be bit by the rattlesnake and be killed. So Synanon really devolved into this violent maniacal cult by this cult leader. And the 70s were kind of, you know, there's other cults that came up in the 70s, and it's kind of a strange period of time. But the foundations of the treatment therapeutic communities were in Synanon, and are known to really be a pioneering force for treatment of the 1900s and early 2000s. And it got professional support. You know, people like Abraham Maslow, if you know Maslow's hierarchy, they professed that Synanon would completely replace psychiatry in 10 years. You know, and there really was this energy that that with Synanon or these types of modalities that you didn't need medications, or you know, that there were other solutions besides psychiatry to things, and that from their approach. In 1969, graduation from Synanon was abolished. It's a little different, but there's still hints of this type of perspective. You know, that they just saw addiction as a terminal disease that could only be arrested by sustained engagement. I think even that was even kind of, you know, not exactly what maybe mentioned earlier, but you know, ever cured, you have potential for relapse on any given day. But to show the explosion, by 1975, 500 drug residential programs modeled upon Synanon type therapeutic communities are in existence. It grows from there in other ways in adolescent treatment. And some of the principles and methods that are still strong tones in the in addiction treatment and recovery communities are that addiction is not a primary disorder, but a symptom of a deeper problem, such as such as a coping mechanism to mask feelings. And some of the methods are to strip all sense of self, any kind of superficial images, and create a psychological nakedness, and then peer persuasion. And these tactics can be prone to humiliation. These can be prone to tactics of humiliation and abuse. So this is a map of Synanon-inspired adolescent treatment programs, and it's just to show that the network is large. They still exist. They're not as prominent as they were in the 90s and 2000s, but there's many of these troubled teen industry teen treatment centers still employing many of these kind of degrading tactics. And recently, Paris Hilton came out to speak out against some of these programs as well, which I think is a good thing for the cause. So just a little acknowledgement. So Bill White for the prior slides, and we're gonna have a couple of videos. So Bill White, I referenced some of the history through his book. It's a great book, and I look forward to reading more of it. And then Marcus Chatfield has written about these teen treatment centers and holistic teen treatment, and he has identified 7 common characteristics that I think are spot on. And we won't necessarily cover them at the moment. It's just that and these happen at different varying degrees of level, but things like philosophy of total personal transformation and things, but under coercion and things of that nature, and these really highly controlled communications where you're cut off from any interaction with society and stuff. So we have a couple just little short clips, and I'm gonna post them in the chat.
I don't care if you sit in these blue chairs until you're 79. You're safe here, and you're not going anywhere. Now sit down. Look at me. Now sit down! Sit down! You're helping these kids.
The trailer's done for most people, but the idea, so why that's shared is because it shows how these punitive policies can really lead to these extreme in support for these so while that's a dramatized version of true events, this is the same type of experience but as a documentary in people's own words. So this is another link to another trailer of a documentary.
Many good people have been convinced that civilization is collapsing, and is collapsing around their children. And they see their children trying drugs and get convinced that they're going to die.
Our parents thought they took us someplace with professionals with an amazing success rate, the best place in the country. Princess Diana, Nancy Reagan, George Bush, 1,000 points alike. They thought they had the best possible place in the world. When in reality, they were just creating molded tin soldiers.
Straight Incorporated is a drug treatment program for children from 12 to 22. Although there aren't qualified professionals on hand, most of the drug therapy is conducted by other kids at different stages in the program.
Not only were the kids unqualified, but there was nobody there who had any serious qualification to be providing therapy of any kind to anybody for anything.
Now think of a situation in which people are told you can physically, mentally, and emotionally abuse other people in this group because you're doing them a favor.
Children will be incredibly cruel in that kind of environment. You're setting up a board of the flies.
The least human parts of all of us came out because that kind of anger comes from fear. It doesn't come from anything else, it just comes from being scared shitless.
Some of the things I saw children do to other children were more brutal than murderers, rapists, and felons that I know and have associated with in my life. And I need to let the people know responsible that we remember, and we're not a bunch of teenagers anymore. I'm going to tell the world about how you destroyed families. I'm going to let them know the things, the horrible things you taught children to do to each other, and how people killed themselves to get away from you.
One of these compounds could be right down the street. There's probably these places in every state in our union, and people are just turning a blind eye to it. I mean, my gosh, to think that there are thousands and thousands of children, of adolescents, young adults being subjected to this kind of abuse, it's horrendous. And it's something that we as a society have to do something about.
During the Vietnam War, we heard the phrase, we had to destroy the village in order to save it. Well, some parents have said, I've got to destroy my kid in order to save it.
Look at us. It's a bunch of broken kids. But here we are, and they're still doing it to other kids.
How's the trailer? Is it still going, or? So I would argue in many ways that society is still doing these kinds of injustice, but these are more intense levels or more intense settings for what society continues to do in many ways. So change is needed. And just to put some numbers, you know, 57.2 million people in the past year have used some type of substance, from marijuana down to heroin. And that's 20% of Americans. And for teenagers and early adults, 12 to 17, substance use disorder, including alcohol and illicit substances, is 1.3 million people, and 18 to 25, 5.6 million people. That's almost 8 million people. That's a lot of 7 million people. That's a lot of people. And why else do we care? Is that we're having record number of overdoses, and 2020 is going to be only worse. And 70,000 people per year means that there's more deaths from substance use than car accidents. It means it's the leading cause of death for people under of all causes under 50 years old. So it's a major problem, and it also leads us to asking, what is effective prevention, and why I think prevention matters is because I think that's reasons why we have the policies that we have, is people think that it's the best way to best form prevention is through criminalization, and really it's a mindset that's, we don't care about those that have a problem, because there's not the solutions aren't good, or they can't be helped, or they deserve it, or they're to blame. Meanwhile, we need to actually ask ourselves with these kind of numbers, are we even doing prevention well at all? And what current policies have done, in my view, is exacerbate the problem for those that use substances. So we've had a very binary approach. You know, stigmatize it, criminalize it, use it at your own peril. You know, you could be a kid playing a video game at the arcade, and you know, just say no, or winners don't use drugs, or kind of everything. You know, but really put up this wall between substance using and substance non-using. Meanwhile, through these, you know, harsh environments, really exacerbating those that use substances and their outcomes and their quality of life. So it's pushed these down in the quality of life for those that use the substance. And emerging perspectives that are increasing in support politically, socially, and across the board. With harm reduction, the aim is to improve the quality of life for those that use substances and get them, you know, improve their quality of life, you know, through principles of healthcare, moderation, safety, in that vein. So it's a good time to remind us of the pragmatic definition of addiction. Addiction, you know, you could just simply state it as substance use in spite of the consequences. And the direct implication of that is that consequences are not an effective bridge to help. So consequences rarely ever are therapeutic for somebody struggling from addiction. And it's tough because many will argue, well, I wouldn't stop unless I had consequences. So how we grapple that challenge really is at the crux of the issue. But I would just put us back to this slide and say, you know, imposing consequences tends to push and threaten the quality of life for someone using, not help. Okay, so that's I can't say any louder. Okay, so it's time to get us into present day. What are some things that we need to know in 2020? Harm reductionist toolkit and leading medicine. We do have solutions that are helping save lives. You know, Narcan is ever present these days. Really strong support to get out there to the street and the people that need it, that can help others. There's fentanyl strips for toxicity testing. You can test your supply, for lack of a better word, you know, see if that's fentanyl in it. There's, you know, for pathogen protection, safe exchange programs for needles, or syringe exchange programs. And then Suboxone is a medication. It's grown in popularity due to its overdose, you know, lack of overdose potential. It's got a ceiling effect that kind of makes it hard to overdose on Suboxone. Other things you need to know in 2020 are language matters. Terms not to use: addict, substance abuse, ex-addict, relapse, drug replacement therapy, or substitution. And terms to use: people who use drugs, substance misuse, person recovery, recurrence of use, medication-assisted treatment or recovery. So it's good to actually take a step back and talk about how stigma even affects our view of these tools, like fentanyl strips. I mean, the typical person would say, why the heck would you test for fentanyl in a drug that's illegal, you shouldn't be using? Well, the argument is to be practical and pragmatic. And same here with our language. You know, we have grown to be sensitive in language to every other community, but we have to fight really, really hard to use sensitive language for those that use drugs. What else? COVID-19 is increasing opioid overdoses. There's a lot that can be taken from this slide. The point is, I don't know if you can see my cursor. I think you can. We see emergency respondents to overdose increasing greater than 30% in these areas, meaning that people are overdosing more. Meanwhile, we're not seeing deaths increase as well at the same level. So there's some good and bad here. So it's saying COVID is increasing the propensity for people to overdose, and the overdose numbers are likely to increase for 2020. Meanwhile, it's also saying, this is real-time tracking, that when we have the tools like Narcan, and we have emergency response, we do save lives. And that's a really positive thing to be saying. If they're not seeing the same level, now granted, there's low data in some of these cases, but if you take it at face value, it's saying EMS is effective for getting out to people that are overdosing, and that's a good thing. Advances in drug policy. So Oregon has become the first state to decriminalize drugs. This is probably controversial, but again, I'll just like take us back to that slide I was showing, that consequences rarely are an effective bridge until maybe you completely break somebody, and that's pretty tall order to do. Many people die before they ever get to that help. Recently, in the last couple of weeks, there's been 34. I assume it's the summation of these two. That $34 billion has been awarded to states and localities due to the pharmaceutical industry's role in fueling the opioid crisis. Purdue Pharma had to pay out, Johnson & Johnson, others. And it's time to end the stigma. So, for example, 80% of those that had their wisdom teeth extracted filled an opioid prescription. And this is a report from 2018 in JAMA. And this is millions of people. So it's millions of people that get their wisdom teeth pulled, and millions of adolescents and early emerging adulthood fill their opioid prescriptions and at a heightened risk of addiction or substance use, or using an opioid prescription again in the following year. So, so what this has also helped with, and we see an old newspaper article about Ryan White, is that, and I think it's a little bit to help explain why attitudes are a little better in 2020 than they were, let's say, in 2014 or 2015, just a few years ago, is that a little bit of the blame, a little bit of came off those that misuse substances. In contrast to the 80s and 90s, and there's a racial side of it as well, prominent racial side of it, not as well, but prominent, but the crack and meth. And the user took the full blame, and then the racial side of it with crack and harsh sentencing, destroying a generation of the Black community, of young people. But so like Ryan White, where he got AIDS from being a hemophiliac and a contaminated blood supply, and it wasn't his fault, and now society rallied around an innocent child, and it wasn't the stigmatized LGBTQ community. A little bit's happened here in the same vein, when somebody could have had their wisdom tooth pulled and now becomes addicted, or a soccer mom, or from a car accident or an injury, or any of the paths that were atypical or not as seen as to blame before. And while that is a good thing that shift is occurring, it's not a complete picture, though. It's an addiction crisis, not an opioid crisis. So science equals solutions. So this is BosLabs, and we are, and as part of ending the stigma, we need change and end the stigma. And I think science is the path forward, and science equals solutions. And really just that, when society is governed by fear, or governed by lack of solutions, or lack of understanding, or what works, then other viewpoints and things come to the forefront. that we've seen for the last 100 years. So I like this model for understanding. Here they do it in the view of alcoholism, but you could do it for depression, you can do it for addiction. I like the model Diathesis-Stress model, and basically it's a nature and nurture perspective, where a person has their genetics, their diathesis, their predisposition to a condition, whether it be in terms of LMI, mental health, mental illness, and addiction. And you have stressors in the environment that interplay with that predisposition. And the tools of science, and we won't have time to get into these tools on this presentation, but twin studies and genome-wide association studies have really demonstrated a genetic liability, their ability to addiction, and we know that trauma, adverse childhood experiences, the ACEs score are really impactful on whether somebody will struggle with mental health and or have addiction or seek support through substances. The neurobiology of addiction, we'll just touch on this a little bit. And this was not the most complicated slide I had. I took that one out. But the message here is two things, just a little bit to learn. The VTA and its role and its projections into the mesolimbic and the cortical systems, and the substances act on nucleus accumbens in the VTA. So you learn a little bit of something, a little multiple choice, test later on. But just a little bit that in the dopamine, the glutamate, in the cortex, the cortex and the midbrain. But I mean, we're getting really well. The take-home message here is that we're getting really good at understanding the circuitry of the brain and how these centers interact and in ways to manipulate them. And that's promising. We didn't have these tools 100 years ago. We didn't have these tools 200 years ago. We had a philosophy, we had a concept. But science in 2020 is on the verge of having everything at its fingertips that it needs to be able to interrupt these circuits. And that will have positive impact in understanding them. And just a little more about, tease out a little bit of biology in terms of, it's the circuitry and epigenetics. But it just, even models behind the stage of use, or from drinking and intoxication to withdrawal to anticipation. So different stages had different circuitry that we're being able to map out as well. This is one of my favorite slides, and this is my favorite biology. So now, and the idea behind modeling human brain circuitry and using pluripotent stem cells is, one, we can get at the genetics. You have a condition, you carry that DNA. We can make neurons that harbor your DNA to have your genetic programming. That's one of the principles behind iPS cells. The other one, another one is that, I have videos of us having a paralyzed mouse walk again from stem cells. Like, we can cure a mouse of paralysis, but that doesn't translate to humans. We haven't yet to cure somebody of paralysis. And now a spinal cord is a conserved structure, right? So it just means that we have to do things in human systems as well for that translational medicine. So, this is pretty cool. We can get at circuitry. We get the beginning steps of circuitry of the brain. There's different models for doing this. We have brain organoids. We can what they call assembloids here, which is kind of nice, just two organoids put together. This one could be like the midbrain. This one could be the cortical. Now you start getting a little bit kind of at the midbrain, the cortical here. And they got microfluidic devices. They're a little more engineered structures and other advanced forms of modeling circuitry, neurocircuitry, but we're getting there. And this is what, neurons in a dish can look like, unsophisticated set of neurons. We're also getting good at the molecular dissection. So in this particular study, this just as, for example, they looked at morphine, but we're able to tease out the parts of the striatum, and here are the nucleus accumbens, and look at the different cell types of the nucleus accumbens. So really exciting. We're getting at per cell resolution. We can understand how each individual cell is interacting with other cells. And there's just a lot of different advanced biology that we can pursue here. But the take-home message is that we're getting at the exact resolution we need to be able to understand things like addiction, depression, schizophrenia, these various conditions. And while we've been limited by scientific approaches in the past, I would like to say that we're increasingly seeing those limitations removed. I'm a little bit of bias towards stem cells, so I find this a nice example. And while I wouldn't necessarily call this a treatment plan, this maybe even be called preventative or prevention, a new way to look at prevention. But it's a way to treat back pain. Leading cause why people use opiates and why they get it initiated to abuse them, and down the line. And this is stem cell therapy for lower back pain. It's a large study. It reads out in the fourth quarter of this year. We might find out that we have a new treatment for back pain. That would be pretty cool. Other technologies that are just really powerful in transforming the treatment landscape that are very exciting. Digital health and supports. This is certainly not all the companies. This is about 50 companies here. They tend to be on the startup side of things, but they're involved in things of cognitive behavioral therapy like paratherapeutics to telemedicine to wearables and monitoring. But just really impressive technology to try to understand through various measures like activity and sleep and cognition, what is somebody's symptomology space. And that's actually how I got brought into Boston and Harvard, is that working in a lab where they were mapping symptomology space all the way down to the cellular level. So taking these two together and learning what works for whom and when are very exciting. And not only are we getting cellular resolution, but we're getting symptomology resolution. Next 10 to 20 years are extremely exciting for what it holds for these conditions. This is the bridge device. It works on the vagus nerve, and it's not. The testimonials are very good on it, so you would speculate that it would be better known than it is, and it's not well known. And but I hear really good things about it, that it is effective for opioid withdrawal treatment, and it's an example of where we really need to be supporting science and technology more than we are as a field. This is a concept technology. The next two slides are quite interesting. And the idea here is, what if you could wear a ring that communicated with your smartphone? And if that ring could detect your respiration levels, then if you were in the middle of an opioid overdose, and it detected the depressed respiration, then it could alert friends and family. And this is the kind of technology that exists, that all the pieces here are out there, but aren't yet put together in one device. But this is the kind of thing that I think that will save lives. So it's really inspiring. This is a similar technology. And so let me underscore the concept here. It measures respiration and alerts friends and family and emergency responders. Okay. Now, this is another technology, the biomode, that exists, or is in pilot phasing or prototype. It's an injectable opioid sensor. It's very small. See the penny, you see the size of it, like a grain of rice. It goes under your skin. It communicates with the wearable that communicates with your smartphone, and it can alert family and friends. Now, this is not a respiration measure. This is the presence of a substance. So if it detects the presence of opioids. So it's a little bit slightly different. You got to think for a second about how that would be applied. One is you've taken too much opioids, and now you have depressed respiration, and they could pick up the respiration. One is, do you have any opioids in your body, or how much? What is your level? And you could get maybe maybe a toxicological readout possibly in that case. But the concept is to detect, measure, and track use of opioids for intervention and safety. So I don't know that the overdose is as clear here. I think that probably is a goal. I'm not sure. But these are leading technologies that are coming up. So this leads to question 4. And question 4 is, which of these monitoring systems do you like, and why? So this is a discussion. And we have this one, that's the ring that measures respiration levels, and if you are have depressed respiration or instead of not breathing, it can alert friends and family. This one is, if there's the simplistic view, is that it can measure the presence of opioids. Let's say you relapse or something, or it can measure that you have opioids in your system.
Joe, did they ever think combining the ring where you're sensing respiration, where you could self-inject the antagonist for yourself and prevent? So it seems like, you know, letting family and friends know is great if they can find you and are close enough, right? So
there are injection devices that are being considered.
Okay.
And what I learned in here that actually was not as where before this presentation is just how small these things are. It's really small. But it's not clear. You know, the ethics here is not clear as well, right? So let me help out the discussion a little bit. So what about the ethics, right? Do you have to, this is invasive, it's inside your body. You cross it, even though it's small and it probably doesn't hurt, and you know, and it's about the size of a thorn, you still cross a barrier. You still cross a barrier of being inside somebody's body, and where does choice? You know, here you can take the ring off if you want. You know, and then so now you get back to some of the questions, some of the perspectives in the beginning of the presentation. You know, do I have a right to choice? Should I have a right to choice? Can somebody force me? And you know, it's very interesting. But these technologies to help out, and the fact that these technologies are being developed, you know, it's a good thing. I mean, people are, I will say, you know, for all the stigma and draconianism and punitive measures out there, there are a lot of exciting science that's being developed for this. So does anybody have I didn't do a vote on here. There's not a poll for. Does anybody have any thoughts on what they like or what they prefer?
Sean in the chat says implant with consent.
Awesome. Okay, so now we have a couple more technology, and then okay, so great. So now, question 5. This is a poll question. I'm still on the other poll question. Let me try. So trying to get to the question, and if I don't get to the question by poll, I'll just ask it. Okay, so the next question is, what is worse, addiction or Parkinson's disease? We could use the chat, I guess, or we could verbalize it.
Oh, wow.
And I'll give it a minute for this one because it's. So the question was, what is worse, Parkinson's disease or addiction? And it's okay to say neither, both are very bad. So if you think neither, both are very bad, you have an empathetic ear for me, because I agree. So now, so here is, this came out last year. It's in the popular press. In the U.S., for the first opioid addicted patient has had electrodes implanted into his brain for deep brain stimulation. And somebody posts on Facebook, and we get all these comments, and people are like, this is sci-fi, this is horrible, this is like all kinds of negative comments. And I'll come back to that. Just FYI, there's several clinical trials going on, quite a few in China for this 13. Seems to be globally 13. So everybody's, a lot of pushback on just, who would do this, all that kind of stuff. But now, deep brain stimulation is done for Parkinson's disease, and nobody would question it, I think. The testimonials are good here, that deep brain stimulation works very well for Parkinson's disease. So that's why I asked the question, which is worse, because deep brain stimulation for Parkinson's disease and MGH is doing for epilepsy and other conditions seems to have a lot of support. So where's this gap? Where's this gap between the science and the community and understanding our acceptance and what is leading to that? So that's why I mentioned that. Okay, great. Okay, so now I have a video. Let me get the link for it.
Joe, what is the controversy around using deep brain stimulation for addiction?
I think there are some good questions and concerns. I don't think that the community response was basing on the ones that that are there, but maybe it's a natural reaction to fear and not really knowing why they're uncomfortable with it. But the one will be, it's not a cure. Does a cure exist? Does it, you could put these electrodes in somebody, and if they still go use because it's a willpower type of thing, then so almost ultimately, I think that the hesitation towards science is this idea that it won't work. And it's really through this idea that science isn't sufficient. There's just a bias against science as a whole. And in fact, in one of the articles that were discussing this in the China trial, the patient was saying just how much he could influence his feelings through these electrodes. So now the other thing is that maybe we as a people aren't comfortable with how effective we can be at modulating neural circuitry.
Right.
And there's another issue there. Let me send a link. I think y'all will really like this video. And it really tells the points of many things that we're saying. So this link is to a panel of Neurobiology and some other scientists at the World Science Festival in 2014, talking about addiction and the craving brain. But you'll find a particularly powerful excerpt here. It's six minutes long, and I think that you'll enjoy it.
Also involved. Getting back to your vaccines, have they been tested on humans?
They have. Cocaine and nicotine are in clinical trials.
And when might these things hit the market?
Well, when the FDA feels they're good enough to be approved. Some of them are still they're still lacking in terms of getting the immune response strong enough. There's a lot of variability, as you might, obviously diversity in our population, and so the vaccines can work well on some people and don't work so well in others. So those are some things that we need to look at a little more closely. And the other big thing is you're saying how quickly we can move these things forward. I don't know any drug company that's working on any of these vaccines except for one company that's working on nicotine. They will not work on any of these, on heroin. I have tried to go to every major company, biotech companies, Wall Street people saying, hey, would you be interested in funding a heroin vaccine moving forward that we could develop. And it's really, they're saying, wow, this is really interesting. You know, I knew someone that overdosed on this. It's great work you're doing, fantastic, but we just don't see a market for it.
Really?
Yeah. It's the cost, it's how much they think they're going to get back.
But there clearly is a market
There is
for
a-
it, and
well, it's a, you know,
drug
it's a
companies
billion
want
do-
profits. I mean, why wouldn't they want to market something that they could readily sell?
You know what, maybe, you know, I don't know a lot of HMOs that cover, you know, crack addicts or heroin addicts. So nicotine, smoking, one thing, but they're not, you know, in terms of what they're going to get back, if they're going to try to go forward and make this, Nora can comment more. But to develop a vaccine, the vaccine itself is extremely inexpensive. That's why I thought for third world countries for heroin. Once you have the vaccine made, it's inexpensive. But to move these through clinical trials costs probably $40, $50 million at the end of the day. And so for them to put that investment in that and what they're going to get back in return is what drives these things, I think. And so, yeah, the value's there.
And you know, you asked me at the beginning about policy issue, and this is one of the most sensitive ones because the science in the whole field of substance abuse is advanced to the point that we could have much better intervention, not just based on immunotherapies, vaccines, and monoclonal antibodies, but actually on medications. But we have this huge gap because the pharmaceutical industry does not feel that there is a profit to be made on the development of these type of medications. Now, this was reviewed many years ago, more than 15 years ago, by the Institute of Medicine that came back and said there should be an incentivization of the pharmaceuticals to go after that, just like we've done in vaccines in this country. If you don't incentivize, the companies are not going to develop vaccines for many of the diseases of childhood. Mm-hmm. My perspective is you're not going to be making money with tanks, but if there is a war, you need to develop tanks, and you then create an incentive because this is...
That was mood lighting, everybody. Yes, no.
So the bottom line is that this is an issue where if we were to create incentives that actually would cost no money to the government, you just, for example, increase the patent that they could get, and the IOM had a whole list of incentives that could be made to accelerate the process. What Kim is saying is actually very, very relevant with respect to the heroin vaccine, because the injection of heroin is the #1 driver of the HIV epidemic in many countries in the world. Mm. And yet, this could be completely averted if there was a treatment intervention such as a vaccine for heroin. And so what is very exasperating is that you have the know-how, you have the knowledge, you know the road, but there is not the resources to move forward in that road. And yet you know that the cost of not moving forward in that road are just gigantic. So that's a little bit of the issues that we play with policy on a field that is stigmatized. So it's stigmatized in the healthcare system, and it's not considered one that is worthwhile of investments by private industry.
Why is it stigmatized in the healthcare system? I understand, definitely when you talk to addicts or addicts' families, co-workers, you understand the stigma, but why in the healthcare? I mean, I'm not saying I agree with it. I think it's a terrible thing.
People who are drug addicts are difficult patients. They're difficult for the system, they're difficult for doctors and nurses, just as they're difficult for their family members. Mm. It's part of the disease.
And also the other thing too, they are not easy patients because they are in themselves in a lot of turmoil, but also because there is a belief that they are to blame for the consequences of their disease, and that is where a lot of
society is telling them that.
Yeah, but that's the healthcare system says it's a lifestyle choice, and when I came to NIDA, I was asking, well, how can an insurance deny the treatment for a substance abusers, whether it's nicotine or it's alcohol? And the justification were to one of them, there are no treatments that work, and the other one, this is a lifestyle choice. Well, a lot of the diseases that we develop in chronic, many of them are related to behaviors that we are doing, and yet we never question it. So we treat addiction in a different way.
how does the vaccine work? What's the proposed mechanism for a vaccine for? I'd never heard of that.
I actually would have to look into that.
Okay.
Yeah, but it's interesting. So it's really interesting because a couple things. You know, if somebody, you know, drank alcohol, let's say, and when they drank alcohol, they had trouble like not using something else that they didn't want to use, right? So, you know, the vaccine, you know, might be able to keep it at the alcohol level, for example. Nonetheless, you know, the idea that, you know, pharmaceutical companies aren't supporting it's a little disheartening, you know, and you know, according to Jim. So, you know, it's a little, and it's an example where society needs to say, hey, we need this, you know, and it's an example where, you know, we need, you know, advocate for, you know, to support for it. If it has the viability that it seems like it has, you know, and I've always wondered, you know, we've heard about vaccines for years and why they haven't, you know, been made available, you know, and he talks a little bit about there's some biological challenges, but it seems to work. You know, it seems like this, or at least be a viable path, and it would be very effective. So just you know, in our last few moments, Love Mind Institute. I'll just return back to us a little bit. Our education outreach programs. We have launched a clinical trials education. It's a utility where people can learn about clinical trials in their area. They can find them. It's a curated list currently. But you know, we're wanting to continue to advance this tool. It fits with our mission of educating the public about the science, about emerging technologies, and then you know the potential here, to, you know, to support those that are needing, you know, innovative strategies is huge, and I think this is a really exciting effort on our part. Our short-term goals are to educate the public about emerging technologies like we've done today on this webinar, as well as what's available in their local community. And with that, it's a big thank you. Thank you guys for everybody that has shown up. I'm glad to have questions. I know we don't have a lot of time left, but I'm glad, you know, if there's questions, I'm glad to.
Joe, thank you for that very insightful overview, and for you know, I didn't know all of the history, and I'm now hopeful to see that there's, you know, a lot of different approaches that could be used to address this, you know, just not through developing another medication, but that there are these software-based. I'm amazed at the vagal nerve stimulator. I come from the field of epilepsy, and that has a lot of help for those patients. So it's kind of exciting to see that it has, you know, other uses too. So yeah, thank you, Joe. I guess I'll ask a question about the vagal nerve stimulator. Are they doing clinical trials with that, or is it?
So that's been FDA approved. So
yeah,
that's actually, that bridge device is FDA approved. Probably likely there'll be more devices as well, and maybe there's other nerves. That's on the well, I have to go back and look at the Auricular part. But it, you know, my initial, when I first heard of it, I thought, how is it going to be effective enough? Withdrawal pains are so powerful. How is this going? And it just speaks to, you know, I'm even a scientist, and there's the bias that science is never good enough or strong enough against the power of drugs. You know, they're just so powerful, you know, that, you know, nothing works against them. You know, but the testimonials are good. I've seen it on YouTube. I've watched it. But others, I've gone and I've asked questions. What have you heard about it? And people say it's effective. You know, so now you have to ask, why aren't more people using it?
I had another question, Joe, and I
Yeah.
don't mean to take up the time. So are there new developments in sort of the behavioral therapy side? And then in addition to that, do companies have a hard time recruiting
Yeah.
to, you know, clinical trials and stuff like that?
I think there are advances in behavioral therapy, because like we saw the videos before of what behavioral therapy was just not that long ago. So it wouldn't take much to improve by just talking nice to someone.
Yeah, true.
Let's just talk nice to give them the respect that they're a human being. That would be step one towards improvements in behavioral therapy. There's really this idea that anything that the person with addiction had, anything they wanted was them being manipulative. It's insane the amount of just dehumanization that those that went into treatment encountered, and so there's definitely improvements there. And there was a second part to your question. What was it?
Oh, about recruitment to clinical trials.
Yeah, there are clinical trials across the board. You'll see them taking years to get done because enrollment's low, and the numbers are here. There's a lot, 23 million people are said to be in recovery. Millions of people are using. We don't have a numbers problem when it comes to substance misuse, or substance use. There's not a numbers problem. But the enrollment's not great, and part of it's the bias. People aren't aware. They don't know they exist. They don't even know how they work. They don't know how to enroll. And then there's the bias that it won't work. It's just the person's to blame. So I think there's a huge unmet need there to support clinical trials.
Thank you, Joe. Does anybody else have a question? And if they don't feel comfortable asking, but they want to put it in the chat channel, I can ask Joe.
There's one question about my research. So I currently work on Huntington's disease. We study the striatum, and we study repeat instability in particular. And we're employing all these techniques of patient-based modeling, iPS cells, single-cell technologies for transcription readout and genomics. And then part of my project includes looking at de novo protein discovery for DNA binding proteins, and which can be translated to epigenetics as well for regulation of transcription. So a lot of the biology employ those methods in my bench life.
Sean says titration with cognitive behavioral therapy has some pretty startling results.
What do you mean by titration? Oh, you mean the lower dose of the substance? Yeah.
Yes. Yeah. Are there any other alternatives to the current antagonist out there that are being used or in development that you know of?
There are a lot of small molecules in development and pipeline. I didn't get into those in this presentation, but there are a lot.
Does anybody else have a question for Joe?
I'm sorry.
Oh no, go ahead. Go ahead.
All right, so I was looking on Google a little bit more information about how a anti-drug addiction vaccine would work, and so what it was saying is that the immune response is generated so that antibodies tag on to the drug itself, and then that complex between the drug and the antibody makes it too big for it to pass through the blood-brain barrier, which seems feasible, although the only challenge is that usually I don't know what kind of immune cell would generate antibodies toward, or how you'd get immune cells that generate antibodies towards a small molecule substance. But if so, how exactly would it play out afterwards with the drug antibody complex just kind of roaming around the bloodstream? How do you think the body would dispose of that, or what do you think would play out from there?
So I think in the Neuroscience Festival panel, I think I was Jim Gonda, I probably remember his name correctly. he speaks to that in terms of opiates and heroin, and its half-life, and it's able to, once it doesn't cross blood-brain barrier quickly, then it's, its half-life does the job for you. So I think it'd probably be drug specific, but that's where I would have to do more. I'd look into a little bit more.
Okay.
Yeah, fascinating. Laurel asked about EMS.
EMS, or wait, can
Do you know about EMS from Laurel?
well, I guess I don't. I wanted to know what it stands for. Okay, so there's TMS, and then there's transcranial magnetic stimulation, and EMS. I don't know about EMS, and TMS. I really didn't get to in this presentation a little bit. That is not specific as deep brain stimulation, but I don't know the specifics of TMS all that well. But it's been used for depression. And people are using it for addiction, and there's hope to get better. I think hope is to get more targeted with TMS, but I'm not exactly sure. And then EMS, I don't know exactly, Laurel. That's got to be similar to TMS, right? So it's magnetic and transcranial.
Yeah.
Yes, TMS is being used for mood disorders very much. It probably has applications here.
Thank you, Jacob, for looking up that. Jacob mentions that vaccine mechanisms for addiction, one was described for alcohol that would essentially give a person an instant hangover once they consumed alcohol.
Yeah.
So I guess pairing with a very negative experience so you don't reinforce the behavior.
Right, I think that's what I was looking at. They were kind of injecting the person, saying that it would last for several months and it would actually work on the liver so that the liver wouldn't be able to process the alcohol and the body would instantly have these adverse effects like nausea and headache, and so kind of like instant hangover. So it is probably drug specific, and it would probably work different for every drug. So
That sounds interesting. I feel bad for the person that uses again. I hope they don't use if they gone through that trouble.
Well, they kind of already have something like, well, not like a alcohol vaccine, but the antabuse. I forget the exact mechanism, but basically I know it blocks off certain enzymes so that your body can't process alcohol properly, and it gets you nauseous really fast. Although the main issue is that you have to count on the individual who is using this medication to continue using it, and if they don't want to continue using it, then they're not going to have the positive effects of preventing them from getting addicted to alcohol again.
Yeah, that's tough, right? So this great discussion. And probably, I mean, can't do it justice, tonight necessarily. But how many people in this call have had a drink of alcohol in the last week or 2 weeks? Right. Now imagine you're one of the unlucky people that can't drink alcohol successfully, in quotes. I mean, it's tough, right? Because imagine if somebody said you can never have another drink again. You might say, well, I don't really care about it that much, but maybe you do. Maybe you do. So there's a real battle. There's a real battle and empathy on my end, at least, towards those that struggle with these things, because it's if somebody said you can never do this again, right? So it's easy for us to say, well, that person should never drink again. Well, or we've set up for that same conviction. How about the phone? How about how about not going on social media anymore? Somebody says you can't do social media at all ever again. So it'd be interesting to think about, thinking about what treatments and cures could look like as well.
What you mentioned brings up an interesting perspective. So Forget who it was, but it was an individual that was on Joe Rogan's podcast, and he was saying that instead of saying that he's going to quit using drugs forever, he just says, I'm just not going to use it for a while. I'm just going to take a break from it. And saying that to himself has made it a lot easier for him to just stay away from substances. So, like for example, with me, I've never had like a formal addiction to alcohol, but I'm currently taking a break from it. I just made the personal goal that I wasn't gonna drink for all of November. I'm staying strong to that, and so instead of saying to myself that I'm never gonna drink alcohol again, I'm just saying that I'm just staying away from it for a little while. And to be honest, I'm not even thinking about craving a drink at all, or reaching into my fridge and having the Angry Orchards I just had left over. And to be honest, I wouldn't be surprised if I continue this maybe into December. So, and I've heard quite a few testimonials of addicts have said something similar. So that's an interesting perspective to think about.
Yeah, I like the sober curious movement. That's a pretty nice one. People saying, "Hey, I'm just going to abstain from alcohol." It's permeated our culture so much, and in the slides I showed a picture of Sunday football tailgating, I mean, there really, is this like, it's everywhere. And I mean, if you go out after work and people, you say, "Hey, have a drink," and, somebody suggested, "Hey, maybe not." Everybody's like, "Why?" I mean, there's so much pressure to drink. So the sober curious movement is awesome. And just that, like, maybe I'll not drink for a month. That's where everybody's relationship is a little different, though. Some people battle that, and where somebody else does battle that. That's why I think stigma is such an important thing to, if we can get anything out of the 2020s, and there's hopefully more goals than just stigma. But if we can at least do one thing, it's like shed the stigma for good. It's time to get rid of it. And, we're not even aware of how stigma just, affects every aspect of how we look at this. Why, I asked about the cure because why could, nobody suggested a cure was helping somebody drink normally. Why wouldn't that be a cure? If somebody had has struggled with drinking, we'll just say drinking, right? It could be anything, but we'll go with drinking. If somebody struggled with drinking in a non-consequential way, not having problematic drinking, well, what if there was a way to make it where they could drink non-problematically? That would be a cure, wouldn't it? So we just don't even think that way. We're just so programmed to think that once somebody's labeled as problematic, substance user or a drinker, then they can't have anything ever again, or they will return back to problematic use. And that simple model probably holds true in many cases, but not necessarily in every case, or maybe not in a lot of cases. So.
Grace mentions about the use of hypnosis, maybe.
Yeah, I don't know, but that would.
I think they use that for smoking, right? To stop smoking. Yeah, I think it's an incredibly complex problem, but I'm hopeful to see that there are really, research on a lot of different alternative approaches.
Mm-hmm.
I think that's. I'm leaving hopeful, Joe.
Other perspectives include, back to that slide where I said that we kind of exacerbate the substance users' quality of life by, throwing them in jail or like moving them out of the workforce. I mean, we make it harder for them to get back into the workforce. I mean, we put all these barriers towards them. Even they've already, demonstrated some challenging, some stability issues. Now we make it almost impossible to get, connected back and put all these barriers up. And but another perspective includes, how do we get them support sooner, and how do we lower their not adding consequences onto them, but how do we bridge them into support, so they don't go to the extreme of consequences. We don't keep making things harder and harder just for the sake of saying consequences is good for you. The idea is that, well, if you have consequences, then you'll want to change. So let's add more consequences to you. But again, the definition of addiction or problematic substance use is the pragmatic definition is using in spite of consequences.
Right.
So, bridging that support as opposed to piling on consequences is another way to think of it that doesn't exacerbate the symptomology space.
Yeah, I think that's a really important because, I had a friend who overdosed, and his family really had taken the approach that he had to hit rock bottom. So they removed all family support from him with the understanding that this would be the ultimate consequence, and that would be preventative. And he ended up overdosing on fentanyl. So, looking back, they now really regret that approach,
But parents have struggled and have questioned whether they should even feed their kid. Okay, we can go with, okay, you can't come into my house because you're intoxicated and I don't want that. Okay. I mean, we can discuss that and debate it. But the questioning of actually even feeding your child, parents have been taught that even feeding your child, you're loving the person who's addicted to death, that loving them was killing them. I mean, this, is unconscionable what we've done. And this is still dominant in the mindset, through subtle to extreme perspectives.
Yeah. Grace, you have some great points, Focus on anti-stigma and empathy for those seeking to feel better, alleviate their pain. Whether it's being addicted or the initial emotional stress that led us to the using, find less pain is the best method for societal change. Yep. Any other comments or questions for Joe?
I'm not, so you started with that, didn't you? I'm not exactly sure what the context of that. But let me just go back over to history a little bit. And we see that throughout history, we've gone through these pendulums of support and punishment frequently. So, we need solutions. And it's my hope that science is going to finally break down these walls.
I guess science and partnering with the community, right? You can design it and build it, but somehow you have to reach the right people.
Yes, I agree.
Yeah.
I've lost the chat box, unfortunately.
Oh, so Grace says, I recall seeing the words that stigma is a societal problem. Empathy is missing. When people understand that they all have addictions, it will help. Well, that's a great point, Grace.
I totally agree with that.
Yeah.
I totally agree with that. That we recognize that we all have personal challenges.
Yep.
Something that's often, and it's a support of that, is that there's many behavioral, like diabetes, right? Or smoking. It's a result from a choice you made, a behavioral choice you made that led to a consequential health outcome. And we don't, yell at the person who has lung cancer for smoking cigarettes, and we don't yell at the person who has diabetes for, for eating a donut, and but yeah, we do somehow think that we're helping somebody if I'll use the word abuse, somebody who's using substances.
Yep. Yeah, Grace mentions that, when people understand that they all have addictions, it'll help. Food is a big addiction, and the food we choose to affects our body. Yep, that's a great point, Grace. Yeah, it seems like, we really need better education better ways to take care of the mental health of everybody. Grace says, see all is sacred. Yep, that's a great message.
And the challenge is that it seems like people would improve their behavior. Many times we can say maybe that's abstinence, maybe not, but we'll go with the simple model of abstinence. We think that why don't they just stop? But that's the point. That's what it means. That's the paradox.
So when COVID's at its worst, my friends who worked in the ER said that it was very strange. They didn't see a lot of the overdoses come. And did it pile up? And then when things opened up, the numbers went up, or?
I don't know the exact dynamics of that. But I doubt that those I think the issue was as present then as any.
Yeah.
I think COVID made people's personal challenges go away.
I would imagine it just amplified it. The stress
Yeah.
placed on top of all of that.
Yeah, they just didn't go to the ER probably.
Yeah. Like all the heart disease and everything else, everybody else stayed home.
Yeah.
Now they're begging you to come back to the hospital. So.
That's one spitting twice shy.
Yeah. Grace points out that for some folks, isolation was healing. That's a great point.
Probably for the substance using and recovery community, probably was a challenge. That most of them strive on connection, or even see it as a cornerstone to their lifestyle. Is communicating with others that have similar experiences. So I think it was a challenge, even from substance using to the recovery communities, was a particularly challenging time. Probably still is.
Joe, this has been great. I've learned a ton. So thank you. I really appreciate all the hard work that you put into this.
Thanks. Yeah, I've enjoyed it.
I'm sure we can continue the discussion for hours. There's so much on this topic. It's amazing, Yeah. Does anyone else have a question for Joe? Yeah, I agree. Grace says, I love to see the technology growth. It's really nice to see that people have moved into this space, and are trying to
A lot of companies, and it's a little challenging because there's definitely in the community definitely a lack of trust. I think is a fair way to put it, because I think institutions have really, in many ways, people have felt burned by institutions, or not looking out after their best interests, or trying to profit off of them. And it's just a general lack of trust. And a common phrase is nothing for us without us. So it really behooves these companies to start reaching into those communities and understand what makes them tick, so that they can, one, understand, like any solution-based enterprise, you try to figure out who you're helping and what solutions are pragmatic and will be applied. So it's nice to see all this energy. It was also would be smart of them to reach into the community a little bit more and find out more about what their needs are.
Yeah, that's a great point. Yeah, Grace mentions that you really need to pair empathy and care with the tech, right?
Grace gives me hope. Thank you, Grace.
You're right, Grace.
Somebody gets it.
We all need a little grace in our life, I think. Yeah, she says the empathy and the care really will help get the patients to have buy-in. Yeah, that's true. You know, thank you, Grace, for adoring the scientists. The public likes to paint us as mad scientists taking over the world.
All right. It's another one word.
No, thank you. No, this has been a great discussion, Joe. I think, you know, we could do a part 2.
Yeah. Going some more to science. Yeah.
Yeah. Well, and I think even exploring, you know, I'd love to hear more about the deep brain stimulation.
Mm-hmm.
You know, I think, you know, Grace is on board for sure. But yeah, I think learning even more about some of the new technologies, seeing, you know, I have my personal bias, you know, the deep brain stimulation and the vagal nerve stimulation. But I think that, you know, there's a lot of great things to talk about for that. You know, I had seen one article where they had, you know, implanted someone for mood, and there was this debate about he wanted it turned up, the stimulation, because he wanted to be happier. And the doctor didn't want to turn it up. And there was this concept of like this, you know, discussion between them, like who owns that emotion and who says being too happy is a problem. Like where do you set that if someone comes to you and says, I want to be happy, I want to be, you know, maybe it pushes them into mania, I don't know. But like where do you have a right, and where does the physician have a right not to do something when it comes to things like that? So
yeah.
You know.
Yeah, the precision of device technology is interesting.
Yeah. So, well, this is true. Grace points out that, you know, folks are using this tech on their own. That's very true. Yeah, a health hacker. Yep. We're familiar with that in our community. We're a do-it-yourself biology lab, and
That's
so
right.
we have a lot of people in the community are health hackers. Yeah, which is very interesting. It's 8:59, and
yeah.
so
Yeah.
I think we could go on. And Grace, please,
I actually got to go.
because
I got to go feed some stem cells here in a little bit. Speak about it.
So, but no, this is all great discussions, and so thank you, Joe. It was so insightful, and like I said, I learned a lot, and I'm now I like Grace. I've written down a bunch of things I'm going to go look up. So
that's cool.
Thank you, and I want to thank everyone for taking time out tonight to join us for this. And if you want to learn more about viruses, there's another event that we're sponsoring tomorrow, Chat with a Virologist, which should be quite interesting. I don't think it'll be just about coronavirus. I think it can be any virus, any question you want. And you can see that through our meetup, which sends you over to Eventbrite. But thank you, Joe. Always a pleasure.
Awesome.
Thanks, you guys. Enjoy your evening.